Dear students, I hope the background matches our situation and I have labeled it as the final ticket. Probably it's a final lap for us before the examination, and a lot of miscellaneous chapters shall be included in this group. Welcome to R.A.T.S, Racing Against Time for Students in Pathology. The topics that I shall be covering in today's session will be Hashimoto's and Graves, and either of them have been asked as short notes or have been kept as slides, specimens, cases in surgery and medicine. And interestingly, it is also a theory question in all these three subjects. First, let us go to Hashimoto's. It is a goitrous enlargement, one of the most common causes for a goitrous enlargement of the thyroid. It occurs in regions with iodine sufficiency, not insufficiency, but sufficiency. And it is a non-endemic goiter in children. It is one of the archetypes or the prototypes of autoimmune disorders. Whenever I say autoimmune disorder, that means the body is producing antibodies against itself. Sometimes environmental factors have been quoted to be responsible. When there are some infections, etc., there are some antibodies produced which can cross-react, leading to an antibody reaction. The presentation. Commonly, it occurs in females around 40 years. 30 to 50 years is the range that is given. More common in females, 9:1 is the ratio. It is an autoimmune disorder, and initially the patient can present with hyperthyroidism, which is otherwise called hashitoxicosis. But later on, it results in hypothyroidism. It is said to be associated with HLA-DR5, human leukocyte antigen, DR5. DR means there are three segments in it, DP, DQ and DR, and this comes under DR5. And it is an autoimmune disorder, please remember. And this is for recollection. A normal hypothalamus pituitary axis which goes onto the thyroid producing T3 and T4, which goes to the peripheral tissues, from which you can have a negative feedback either to the pituitary or to the hypothalamus. This is what is normally happening in us. And this is a normal thyroid gland that is given. So you find that there are follicles. These are all thyroid follicles. Whenever I use the word follicle, we should be careful because there can be a lymphoid follicle, there can be a thyroid follicle. These follicles are filled with pinkish glistening substance called colloid, and they are lined by a single layer of flattened cells. And these can be the parathyroid cells which can be present in between. So this is a normal histology. See this well because subsequently I am going to show you a different kind of histology. Now what is the pathogenesis of Hashimoto's thyroiditis? It is a genetically determined disease, but however, it does not manifest until some time. I told you 30 to 40 years. Probably only then the antibodies are being produced. There are two types of reaction that happen from the T helper cells. One can be the production of the cytotoxic T8 cells, which can lead to cytotoxic T lymphocytes, which lead to damage of the cells and apoptosis. So there is a reduction or a destruction. At the other end, I have got the T helper cells which produce the B cells. B cells are the precursors of the plasma cells, and plasma cells are the cells that produce the antibodies. These again act against specific antigens in the cells leading to necrosis or apoptosis. And finally, you find that there is a thyroid cell death which results in hypothyroidism. So it can be genetically determined, and there is a deficiency in the antigen-specific suppressor T cells. As a result of which, you find that there is increased amount of cytotoxic T cell activity on the follicular cells. Also, there can be the production of the B cells and the plasma cells leading to the antibody formation. Please draw this diagram. This again is a superb picture that has been taken from labpedia.net. Worth remembering. What are all the thyroid antibodies? This is a thyroid follicular cell and follicle lined by the flattened cells, and these are all the various antigens: thyroglobulin, thyroid microsome, thyrotropin receptor, and thyroperoxidase. These are all the antigens against which antibodies will be produced, and these are the autoantibodies, which will be leading to an antigen antibody complex, subsequently resulting in inflammation and tissue destruction. Please draw this one. What are all the various antibodies which we can get in Hashimoto's? It can be antimicrosomal antibodies, TSH receptor antibodies, thyroglobulin antibodies, and thyroid hormone antibodies. You will have to mention these antibodies. Also, you can get autoantibodies, in the sense immunoglobulins are there which are already, they are antibodies, but against them we get the antibodies, hence they are called as autoantibodies. Thyroid stimulating immunoglobulin antibodies and thyroid growth immunoglobulin antibodies. So you find that there are a spectrum of antibodies which can be seen in Hashimoto's thyroiditis. This again is a superb diagram which again I would like you people to draw. The thyroid follicle flattened cells leads to the production of the autoantigen. There is a complex, antigen antibody complex, which leads to cytotoxic injury of the cells, tissue destruction. And finally, there is a destruction of the thyroid follicle. Also, the autoantibodies can be seen in other conditions such as chronic lymphocytic thyroiditis, Hashimoto's thyroiditis, collagen diseases, sometimes in thyroid carcinoma, rheumatoid arthritis, pernicious anemia, etc. So these are other disorders. In the sense, whenever you see one autosomal disorder anywhere, try to look for another one, it is likely to be found. A very good mnemonic, and this is the source of it, due credits to them. Hashimoto's thyroiditis. H for hypothyroidism, A for autoimmune, S for synthyroid, the entire thyroid treatment, Hertel cell change, initial acidotoxicosis followed by hypothyroidism, marginal zone lymphoma, which can be seen, goiter, the O is here, and TPO, antimicrosomal or antithyroglobulin antibodies, and lymphocytic infiltrate. So this is the mnemonic, please remember this. And this is the author of the Hashimoto, 1912, who had discovered this disease. Now, what is the gross picture in Hashimoto's thyroiditis? There is a mild goitrous enlargement. Goitrous means it is an enlarged one involving both the lobes, bilateral. It is roughly symmetrical, and there can be mild bossellation. Look at this one. It is not flat. There is a mild bossellation that I find here and there, but there is no nodularity. There is no nodularity. There are two variants of the Hashimoto's. One is called the classical variant, which we shall be seeing. Another is fibrosing variant. A lot of fibrosis is formed within and without the thyroid tissue, and this can sometimes be mimicking a neoplasia. This is a cut surface. Earlier we have seen the external surface, now the cut surface. It is solid, homogeneous. Homogeneous means it is uniform throughout, fleshy. It is soft and fleshy. We can appreciate it from the picture itself. Pale gray or yellowish gray. There is no honeycomb appearance that is present. Honeycomb is a classical picture because of the colloid cell follicles in a thyroid, but that is not seen here. There are no areas of hemorrhage or necrosis. So please remember this. This can be kept as a specimen for us in the examination. Even otherwise, we will have to write the description. And another set of pictures for comparison. This is the Hashimoto's we had described earlier. In this one, I find that there is an enlargement of the thyroid, but then there are multiple nodules of varying sizes. And it is somewhat blackish in color because there can be areas of hemorrhage. So colloid filled follicles, nodularity, areas of hemorrhage, that is a typical picture of a multinodular goiter. The microscopy, as I told you, there are some differences. This is the classical thyroid we had seen earlier, and this is the Hashimoto's thyroiditis. Look at this one. There is a replacement of the thyroid parenchyma by lymphocytes and plasma cells. So there are some lymphocytes, plasma cells here, and sometimes we find that there can be an entire lymphoid follicle that is here. Lymphoid follicle means it is a group of immature cells in the center, and there can be the mature small lymphocytes in the periphery. There can be lymphoid follicles which can be present. All this can lead to atrophy of the thyroid follicles. So compared with this, I find that there is a total atrophy of the thyroid follicle. The colloid is scanty when compared with it, and the follicular epithelial cells, they become large, polygonal, somewhat liver-like cells, hepatocyte-like cells. And they are called the R.A.T.S cells or oxyphilic cells. And they have got a bright eosinophilic cytoplasm. This is the nucleus, this is the cytoplasm. And these are the lymphocytes and plasma cells. Higher magnification of the same, these are labeled over here. You people can go through it. And this is another picture showing the bright eosinophilic cytoplasm of the R.A.T.S cells or oxyphilic cells. This is a slide for recollection. We should remember the antibodies that are present in Hashimoto's. Also, it is symmetrical and solid. Look at this picture. Both the lobes are fairly symmetrical, though not exactly uniform. The cut surface is solid. And microscopically, there will be the lymphocytes and lymphoid follicles. R.A.T.S cells are present, replacing the normal follicular epithelial cells. And there are two variants, namely the classical variant and the second one is the fibrosing variant. This slide is for recollection. Two things to remember. This is my own design mnemonic. If it is bad, please forgive me. There are two variants, classical and fibrosing. Two lobes are involved and they are symmetrical. Two parenchymal cells, cuboidal cells and oxyphilic cells or R.A.T.S cells. Two infiltrating cells, lymphocytes and plasma cells. Two modes of presentation, hyperthyroidism initially and hypothyroidism later on. Two hormones are decreased, T3 and T4. Two complications. It is the usual hypothyroidism, but more important is the non-Hodgkin's lymphoma. Please remember these two things. The next one is a Graves' disease. This is also an autoimmune disorder and it has been named after Sir Robert James Graves. Graves itself is a name. It is not G-R-A-V-E apostrophe S, but G-R-A-V-E-S apostrophe. Surgeon in Ireland, 1796 to 1853. It is a rare disease in 0.4% of the population. Again, females are more commonly involved because it is an autoimmune disorder. It is associated with HLA-DR3. Hashimoto's is DR5, this is HLA-DR3. It is a thyroid disorder in which it is hyperfunctioning. There is again a diffuse hyperplastic goiter and it is toxic in all cases. These are the things that you will have to remember: diffuse hyperplastic goiter, infiltrative ophthalmopathy, and dermatopathy. All the three need not be seen in a case of Graves, but then these are the hallmarks of the Graves disease. And this is your surgeon, Graves. And as I was scrolling through, I picked up a mnemonic. And this is more regarding the ophthalmic counterpart, but I felt it is worth it for the students as well as myself. So these are the various clinical signs that are seen in Graves' disease. Gifford, a lower lid lag, Von Graffe, lid lag on a down gaze, Enroth, lower lid edema, Stellwag, infrequent blinking, Mobius, defective convergence, Kochus, spasmodic retraction of the upper eyelid, Geoffroy's, absent forehead creases, and Darryl-Impulse. There is a lid retraction. So, I do not know much about ophthalmology. I felt that this was extremely useful and interesting. Coming back to pathology as such. So, it is an immunologically mediated disease and there is a chronic edematous inflammation in the retro and the periorbital tissues that leads to coptosis or the projection of the eyes. There is a lid lag. Whenever one closes, you find that the lid lags behind. And why is this projection? It is because of the deposition of hydrophilic mucopolysaccharides in the periorbital and the retroorbital tissues. There is also an edema, there is a lymphocytic infiltrate. All the three may be contributing to this projection. Secondly, the patient may be having an edema of the feet. This is again a very beautiful picture of the Graves' disease wherein there is an edema, some amount of nodularity that is seen in the feet as well as the legs. And this is the source of this picture. It is a very superb picture and it has to be acknowledged. This particular diagram I would like you people to follow. It is quite simple. So again, there are the CD4 helper T cells and whenever there is, they lead to the production of the B cells from which there can be the plasma cells later on and then there will be the production of the antibodies. Whenever I say antibodies, the antibodies usually again act against the thyroid follicular cells or they can act against the orbital fibroblasts or they can act against the skin fibroblasts. That is why you are having changes in the thyroid as well as in the eye and the skin. These are the antibodies. I would like you people to kindly go through it. Other facts are given here. It is genetic but manifests much later due to the mutation producing autoreactive B cells. These are produced later on, that is why there is a late manifestation. And secondly, you find that there is a progressive decline in the suppressor cells. Whenever the suppressor cells are reduced, you find that the antibodies become more active, leading to damage. This is a gross picture. One thing that is striking is both the lobes appear more or less symmetrical. They are solid and symmetrical, somewhat fleshy again in appearance, but here it is described as a beefy red or a meaty red color, whereas it is grayish white in Hashimoto's. This again is a better red color, beefy red or meaty red in color. There is a diffuse hyperplasia involving both the lobes. The weight is increased 80 to 90 grams. The normal weight is 20 to 25 grams. Bilateral, symmetrical. The capsule is intact. This is the capsule outside which is intact. It is glistening and it has got fine granularity. The cut surface, again, it is solid, beefy red, soft, uniform, and it resembles the normal muscle. So this is a gross picture. Microscopically, you find that the parenchyma is cellular. So I'm finding a lot of these thyroid follicles, lot of activity is seen. All the blue dots indicate that it is a nucleus. The follicles are lined by tall columnar cells and there is increased number of cells. We shall be seeing that in the next picture as well. They pile up to produce papillary buds. Sometimes there can be microvilli of the lining cells. And the colloid here, it has got a withdrawn appearance. We call it a scalloping appearance that is seen. So scalloping is something like this. The frills of a garment, I've got exactly that picture. This is a better picture to show that there is a piling up of the cells. This is not a papillary process, but then a piling up of the cells which can be seen. And I'm able to see the empty nodules along the borders, which is the scalloping. And there is a higher magnification of the same. Look at this one. I find that there are heaped up or piled up cells, and this is a colloid. and the colloid itself is getting withdrawn, leading to a scalloping appearance. And a scallop is the border of the garment. The clinical manifestations can be thyrotoxicosis, symmetrical enlargement, ophthalmic manifestation. They usually regress, but if proptosis precedes it, then there can be damage to the eyes, such as corneal injuries, there can be loss of vision, but luckily there is no malignancy in the case of Graves' disease, as in the case of Hashimoto's where you get a lymphoma. I would like you people to describe this one. Appreciate that there is a piling of the cells, the scalloping of it, and there is a pinkish colloid by means of a PAST. Hazy Jidai. Find out the language.